Children are not miniature adults. From infants to teenagers, the anatomy and physiology of the child is in a continuous process of morphing into the adult form. These differences make managing the airway and intubation more challenging than in the adult. This video will build on your basic skill set for adult airway management and intubation to detail how to adapt your techniques to the pediatric patient. Let's review the anatomy of the larynx. The larynx is a muscular tube in the neck that contains the vocal cords. It's the uppermost opening to the tracheobronchial tree and lies anterior to the esophagus. The larynx functions as a sophisticated valve that lets us breathe air, cough effectively, and swallow food and liquid without aspirating. Vibration of the vocal cords vocalizes sounds. The laryngeal skeleton gives the larynx rigidity and support. It's principally formed by the hyoid bone and the thyroid and cricoid cartilages. Attached anteriorly to the inside of the thyroid cartilage is the epiglottis, a curved leaf-shaped structure. Its upper rounded edge projects into the pharynx just behind the tongue. The stalk at the base of the epiglottis allows it to swing up and down over the laryngeal outlet, opening and closing it like a trap door. The depression between the epiglottis and the tongue is called the vallecula. The vocal cords are ligaments that project forward from the arytenoid cartilages to the inside of the thyroid cartilage. The opening to the trachea, called the glottis, lies between them. All the cartilages, ligaments, and muscles are covered by mucosa. Because of the structure of the larynx at any given glottic opening, there is more resistance to inspiration than to expiration. For this reason, conditions causing airway obstruction, such as edema or tumor, usually produce symptoms with inspiration before expiration is even impaired. Protection from aspiration also depends on muscle coordination. During swallowing, the whole larynx rises in the neck, the epiglottis folds over the glottis, and the tongue and pharyngeal muscles direct food and liquid backward into the esophagus. When muscle tone is lost, the epiglottis, tongue, and other pharyngeal tissues fall backward, blocking the larynx and obstructing breathing. A good example of this from everyday experience is snoring. The differences in pediatric airway anatomy are most marked in infants less than 1 year of age. Sometime between the ages of 6 and 8 years, the laryngeal anatomy, although smaller, resembles the adult. Many aspects of the young child's airway anatomy predispose to airway obstruction. The infant's larynx lies higher in the neck, opposite cervical vertebrae 2-3, instead of opposite the adult 5-6. In all adult non-human mammals and in the human infant, the larynx can be elevated so that the epiglottis slides up behind the soft palate to effectively lock the larynx into the nasopharynx. With the soft palate fitted snugly around the larynx, a constricted passage is formed on both sides of the elevated larynx, allowing liquid to pass around the larynx into the esophagus. The tongue is larger relative to the mandible and fills the mouth, angled slightly forward to cover the gum line. These features allow the nursing human newborn to suckle effectively and breathe while swallowing liquid. The ability to breathe and swallow at the same time is called obligate nose breathing. All mammals other than the adult human are obligate nose breathers. However, this anatomical configuration places the child at greater risk of airway obstruction and makes airway management more challenging. A newborn infant breathes through his nose and can suffocate if the nose is obstructed. The only time newborns breathe through their mouths is when crying. A congenital defect known as choanal atresia occurs when the nasal passage is narrowed or blocked by tissue. Newborns with bilateral choanal atresia may need resuscitation at delivery. The baby's relatively large tongue more easily obstructs the airway. The higher position of the larynx in the neck makes the larynx appear more anterior during intubation, since it's harder to displace the surrounding soft tissue forward and out of the line of sight. When supine, the large occiput flexes the head forward, collapsing the tongue and soft tissues over the larynx and blocking the airway. The cartilage composing the trachea is soft and easily compressed. Extreme extension or flexion of the child's neck can obstruct the airway. In fact, pressing on the soft tissue under the chin to get a good mask fit can also obstruct the airway. The larynx is not only smaller than the adults, it's also anatomically different. The epiglottis is shorter and more omega-shaped, making it harder to pick up with the laryngoscope blade. It's softer and more easily deformed. In the adult larynx, the gap through the vocal cords is the smallest diameter. However, in a young child, the smallest diameter is the cricoid cartilage, which is below the vocal cords. This means that you can occasionally pass an endotracheal tube through the vocal cords, but then not through the cricoid ring into the trachea. Never force a tube to pass. Instead, switch to a smaller tube. The cricoid's narrow, rigid, ring-shaped bottleneck also increases the risk of airway obstruction when swelling occurs. Minimal swelling can cause tracheal obstruction because the larynx and the trachea are so small. 1 millimeter of circumferential swelling in an adult with a 10 millimeter trachea causes only a 20% obstruction. The same 1 millimeter circumferential edema in an infant with a 3 millimeter trachea causes a 70% obstruction. Thus, swelling from infections or trauma can have a much more devastating effect. Between 2 and 6 years of age, the larynx gradually descends to a lower position in the neck. At the same time, the posterior part of the tongue descends, gradually forming more and more of the anterior wall of the oropharynx. By 6 to 8 years of age, the upper respiratory system has assumed the adult configuration, and the epiglottis can no longer reach the soft palate, even with maximum elevation. The posterior third of the tongue is now vertically oriented to form the anterior wall of the oropharynx. The nasal passages of older children are often filled with adenoidal tissue. Hypertrophied adenoids and tonsils can fill the dead space in the back of the pharynx, making assisted ventilation more difficult. It's currently estimated that 1 to 3% of children suffer from obstructive sleep apnea, or OSA, a condition more often thought of as an adult disorder. OSA is now the most common reason tonsils and adenoids are removed in children. Pediatric sleep apnea typically appears between the ages of 2 to 6, but it can occur from infancy to adolescence. It's believed to affect girls and boys equally, and it's often undiagnosed. Untreated obstructive sleep apnea in children has been linked to behavior problems, impaired growth, learning disabilities, poor school performance, bedwetting, high blood pressure, and heart disease. Understandably, airway management can be more challenging when such a child loses consciousness or develops airway obstruction from other causes. In addition to anatomical predispositions for airway obstruction, children physiologically develop hypoxia faster than adults. Their smaller lungs and higher metabolic rates leave them with fewer oxygen reserves. The basal metabolic rate of a sleeping infant per kilogram of body weight is approximately double that of an adult. The much higher energy requirements relate to the differences in body proportions. Major organs such as the brain, liver, and kidneys contribute to the higher energy use in infants. These organs use more oxygen than lean muscle mass, which makes up the highest energy user in the adult body. Other contributors to this higher infant metabolic rate are temperature control, because of the higher surface to volume ratio, and rapid growth rate. Although oxygen requirements are higher, a child's immature lungs are not as efficient at providing this oxygen, and the muscles of respiration tire more easily. A normal resting tidal volume is about 8 milliliters per kilogram of lean body weight, regardless of age. However, this can mean a difference in tidal volume from 40 milliliters for a 5-kilogram baby, 160 milliliters for a 20-kilogram toddler, or 800 milliliters for a 100-kilogram man. In the face of such small tidal volumes and their higher oxygen consumption, the infant or toddler must breathe more rapidly than the adult to compensate. For an infant, 30 to 60. For a toddler, 24 to 40. For an adult, 12 to 16 breaths per minute. To breathe effectively, the intercostal muscles and diaphragm contract, increasing chest volume and lowering intrathoracic pressure. Air is pulled into the lungs through the unobstructed airway. Normal elastic recoil of the chest wall then increases intrathoracic pressure and pushes air and carbon dioxide out. The chest rises with inspiration as the lungs expand. It falls with expiration as the lungs deflate. The pediatric chest wall is much less rigid. When airway obstruction develops, the highly compliant chest wall gets sucked inward as the diaphragm drops. The chest wall begins to limit lung expansion and decreases optimal air exchange. The harder a young child tries to breathe, the more inefficient breathing can become. Many things can disrupt the respiratory system and cause it to fail. Hypoxia, or inadequate blood oxygen content, or hypercarbia, or high blood carbon dioxide, can easily occur due to altered mental status, due to medications, underlying illness, or trauma. Upper airway obstruction, such as snoring, sleep apnea, foreign body or swelling. Lower airway obstruction, such as asthma or emphysema. Impaired diffusion of gas from alveoli to capillaries, such as pneumonia, tumor, radiation, or burns. Abnormal pulmonary blood flow, such as shock or heart failure from any cause. Chest wall or diaphragmatic injury, such as broken ribs or ruptured diaphragm. Impaired chest wall and lung motion, such as extreme obesity. Impaired nerve or muscle control, such as spinal cord injury, paralytic drug effect, muscular dystrophy, or stroke. Infants and children are especially vulnerable to respiratory failure because they have little cardiopulmonary reserve. The heart constantly contracts, returning non-oxygenated blood to the lungs to pick up more oxygen, and sending oxygenated blood back out to the rest of the body. With good cardiac output and lung function, oxygen delivery meets oxygen demand, and carbon dioxide is eliminated from the body as it's produced. Young children require a rapid heart rate to maintain an adequate blood pressure and oxygen delivery. Cardiac output is rate dependent because the child's heart muscle and sympathetic nervous system are immature. The need for more oxygen is met by increasing heart rate, not contractility. Pediatric cardiac output drops dangerously with bradycardia because stroke volume cannot increase to deal with increased demand. To make matters worse, children, unlike adults, develop bradycardia more easily. Hypoxia in an adult initially triggers a sympathetic response, producing tachycardia. In a child, hypoxia triggers a vagal response and slows the heart. The slowed heart rate delivers even less oxygen and hypoxia worsens. This combination of increased baseline oxygen demand, limited respiratory reserve, rate-dependent cardiac output, and predisposition to bradycardia puts infants and children at extremely high risk of respiratory failure. Always assume bradycardia in a child means hypoxia and treat the child with oxygen and improve ventilation until proven otherwise. You must recognize and treat bradycardia and hypoxia immediately, or cardiac arrest can occur within minutes. Good airway management is therefore critical. Evaluate the child using 4 criteria: effort to breathe, including rate and depth, mechanics of breathing, color of mucous membrane and skin tones, and cardiovascular response. How hard is the child working to breathe? A patient who is able to maintain adequate oxygenation only by using extra effort to move air and by increasing the breathing rate is in respiratory distress. The degree of distress can be mild, moderate, or severe and is often accompanied by tachycardia. Partial upper or lower airway obstruction alters the mechanics of breathing. Let's look at a patient to see some of these physical signs of obstruction. This 7-year-old girl is about to undergo tonsillectomy for enlarged tonsils and sleep apnea. She's breathing an anesthetic gas. As she loses consciousness, her muscles relax and she starts to obstruct her airway. Watch how the mechanics of her breathing changes. When a patient is working hard to breathe, the accessory muscles of respiration, the sternocleidomastoid and scalene muscles, tends to lift the clavicles and allow fuller expansion of the chest. These muscles become tense and rope-like. Look how the skin over the tracheal notch is sucked inward, an important sign of obstruction. The harder the patient tries to breathe against both upper airway or lower airway obstruction, the more negative pressure is created inside the chest. This pressure differential sucks the soft tissue between ribs and at the sternal notch inward. When the diaphragm descends maximally, it pushes the abdominal contents downward and outward, further decreasing intrathoracic pressure. If the airway is obstructed, no air can enter the chest, and this negative pressure pulls the chest wall inward. A rocking chest motion occurs, with the chest falling and the abdomen rising. This is the opposite of normal inspiratory motion. Other signs of airway obstruction can include poor movement of air in and out of the mouth and nose, nasal flaring, faint or absent breath sounds, head bobbing or grunting, and the inability of the awake patient to phonate. The anesthesia provider opens the airway by pulling up on the jaw, then inserts an oral airway. Look at the difference in chest wall motion now that obstruction is relieved. The chest and often the child's abdomen rise together with inspiration. Breath sounds are heard on auscultation. Air movement returns. When a clear mask is used, this air movement is seen as condensation inside the mask. A patient who, despite extra effort and increased breathing rate, is unable to maintain adequate oxygenation, or who has poor ventilation with carbon dioxide retention, is in respiratory failure. An important sign of respiratory failure is the color of skin and mucous membranes. Cyanosis is the bluish coloration of mucous membranes and skin due to deoxygenated hemoglobin in the blood vessels near the skin surface. It occurs when arterial oxygen saturation falls below 85%. Cyanosis is a late and sometimes unreliable sign of hypoxia because ambient lighting, skin pigment, and severe anemia make it hard to see. An oxygen saturation monitor is much more reliable if you have one. Normal oxygen saturation is 97 to 100% on room air, corresponding to an arterial PO2 of about 100 millimeters of mercury. Be especially alert if your patient's oxygen saturation falls below 90%, corresponding to an arterial PO2 of 60 millimeters of mercury. These values provide the minimum oxygen delivery to prevent metabolic acidosis and will fall quickly below these numbers. You may need to maintain a higher saturation if the patient is anemic. When hypoxia is present, the conscious patient with respiratory distress usually exhibits air hunger. He or she appears anxious and breathes rapidly and deeply. Nonspecific signs of hypoxia and poor ventilation include restlessness, confusion, agitation, tachycardia, hypertension, or sweatiness. Unfortunately, it's easy to be fooled into treating disorientation caused by hypoxia or hypercarbia with sedative medications and unintentionally precipitate respiratory decompensation. Always consider hypoxia and hypercarbia when treating disoriented patients. The faster and more deeply a patient breathes, the more turbulence in the airstream. If upper airway obstruction is present, stridor, a high-pitched, harsh, creaking inspiratory sound, is produced as air moves past a swelling or constriction of the laryngeal structures. This is how stridor sounds. Laryngospasm, croup, and epiglottitis are examples of conditions causing stridor. The patient who is able to sit up should be assisted into the position most comfortable for breathing. Children especially may want to assume the tripod position, leaning forward with their outstretched hands on their knees. This maximally opens the airway and allows full descent of the diaphragm. The child often drools because they can't swallow effectively. They appear exhausted. Croup, epiglottitis, or aspiration of a foreign body present this way. These children are in danger of complete airway obstruction. Someone knowledgeable about airway management must accompany them at all times until the danger from obstruction is past. Avoid agitating the patient. Let them remain sitting and keep them calm. Provide humidified, high-concentration oxygen. Don't force the child to lay down. If severe edema is present, the most experienced intubator should intubate when possible. As airway respiration worsens, the patient will eventually decompensate. Respiratory rate may actually slow and effort decline. Apnea can occur. You must always be vigilant. Look, listen, and feel for air movement. When simple arousal doesn't improve respiration, then you must open the airway yourself. The following maneuvers assume no cervical spine injuries. If cervical spine precautions are needed, use jaw thrust only and maintain a stable head and neck position. With the head in a relaxed and flexed position, the tongue and soft tissues tend to collapse over the larynx and cause obstruction. The oral, pharyngeal, and laryngeal axes are not aligned. A child younger than 2 has a relatively large occiput. Placing a folded towel under the shoulders in this age group aligns the pharyngeal and laryngeal axes. In a child older than 2, placing the towel under the head, as in the adult, is usually more effective. Tilt the head back. Pull the angles of the jaw upward. This puts tension on the base of the tongue and soft tissues and lifts the epiglottis off the trachea. Further thrust of the jaw opens the mouth fully and opens the airway. Extreme extension or flexion of the child's neck can obstruct the airway. In fact, pressing on the soft tissue under the chin can also obstruct the airway. To avoid this, keep the head in a more neutral, slightly extended position. And keep your fingertip pressure on the bony mandible when opening the airway, not the soft tissue under the chin. If obstruction persists, the next step is to insert an oral airway or a nasal airway. An oral airway is a fairly firm, curved piece of plastic which sits on top of the tongue and pulls it and the associated soft tissue forward, away from the top of the larynx. The correct size puts the flange outside the teeth and gum line and positions the tip near the vallecula. To estimate the correct size, place the oral airway next to the patient's jaw and judge where the tip will lie. Too short pushes the tongue back over the larynx, worsening airway obstruction. Too long extends outside the mouth and interferes with mask fit. While an awake patient often won't tolerate an oral airway, it's often a better choice than a nasal airway in unconscious children. The oral airway avoids the risk of bleeding caused when a nasal airway injures hypertrophied adenoids. Open the mouth as wide as you can and insert the oral airway. Slowly advance it until the tip is behind the back of the tongue. You can use a tongue depressor with your left hand to open the mouth and push the tongue down. Place the tongue depressor to the rear of the tongue and pull it forward. You can also invert the airway's curve towards the roof of the mouth. Advance it until the tip lies behind the tongue, then flip it into position. A correctly placed oral airway pulls the tongue forward and opens the mouth. If placed incorrectly, oral airways can increase airway obstruction by pushing the tongue back over the larynx. Oral airways have risks when used in conscious and semi-conscious patients. Risks include stimulating the gag reflex and causing vomiting and aspiration. Compression of lingual vessels and nerves can cause swelling. In addition, the tip of the tongue can get pinched between the oral airway and the lower teeth, producing bleeding or edema. Use caution to avoid tooth damage or mucosal injury. Children often have loose teeth. If you have the time, check for loose or missing teeth before you start. Always recheck the teeth after you've placed an oral airway or intubated. If a tooth is newly missing and you can't find it, get a chest X-ray. Nasal airways are soft, flexible tubes which slide through one side of the nose. This positions the opening of the tube in the posterior pharynx behind the tongue. The opening is often, though not always, in line with the trachea. Choose the largest size to comfortably fit your patient. A nasal airway is often better tolerated in semi-conscious patients because they don't stimulate the gag reflex as much. However, it must be used with caution in pediatric patients. Nasal airways can cause nosebleeds, especially in 3 to 6-year-old children with hypertrophied adenoids. Always lubricate it well with a water-soluble gel. A local anesthetic gel is best because it also numbs the nasal passages. Avoid plugging the tube with gel. Use gentle technique. Direction of insertion is very important. Don't thread the nasal airway upward toward the frontal sinus. Instead, advance it along the floor of the nose, perpendicular to the plane of the face. Never force it. If you meet an obstruction, try rotating the nasal airway as you advance. Adenoidal tissue can plug nasal airways, causing obstruction and potential aspiration of tissue. If it appears plugged, suction the nasal airway to clear it. After opening the airway, check your patient's ventilation. If the patient still isn't breathing well, you should immediately assist or control the respiration. Mouth-to-mouth ventilation is one option. Here, we'll discuss the use of a bag valve mask apparatus. There are different types of bag valve mask devices. Here, you'll see ventilation with either the typical self-filling resuscitation bag, like an ambu bag, or with a free flow or plenum-style anesthesia machine circuit demonstrated. To ventilate a child, first choose the correct size mask. The proper size covers the space between the bridge of the nose and the crease of the chin. The wrong size prevents a good seal. Place the apex of the mask over the bridge of the nose, not its tip. and press firmly. Lower the mask over the cheeks and allow the edges to grab the bunched cheek tissue. The bulk of the cheek now fills the gaps between the mask and the patient. Make sure the lower lip is inside the mask. Note the final position of the fingers. The thumb and forefinger press the mask against the face and form a C shape. The remaining fingers grip the bony mandible and pull upward, forming an E. The mask seal is created by the opposing force of the thumb and index fingers pushing down against the force of the last 3 fingers pulling up on the bony mandible. Don't press on the soft tissue under the chin because this can increase airway obstruction by pushing soft tissue in the epiglottis back over the laryngeal outlet. Placing a small folded towel under an infant's shoulders sometimes helps to open the airway. Pillows are seldom needed and may worsen airway obstruction in a baby or toddler. Protect the eyes. It's easy for the mask to push open the eyelids, exposing the eyes to corneal abrasion. Consider taping them closed if the patient is unconscious. To ventilate, squeeze the bag. The chest should rise with each breath. Both children and adults have a tidal volume of about 8 milliliters per kilogram of body weight. A 10-kilogram child has an 80 milliliter tidal volume. Watch the chest rise as you squeeze the bag to gauge the volume of breath you're delivering and the resistance to ventilation. Pediatric inflation pressures are lower. Use smaller breaths to avoid pneumothorax and stomach distension. Stomach distension hinders lung expansion, promoting hypoxemia and possibly vomiting. If stomach distension becomes significant, you may need to pass a small flexible suction catheter into the stomach to decompress it.
Okay, not much back there. Okay. Notice I'm not really...
A normal resting tidal volume is about 8 milliliters per kilogram of lean body weight, regardless of age. However, this can mean a difference in tidal volume from 40 milliliters for a 5-kilogram baby, 160 milliliters for a 20-kilogram toddler, or 800 milliliters for a 100-kilogram man. In the face of such small tidal volumes and their higher oxygen consumption, the infant or toddler must breathe more rapidly than the adult to compensate. For an infant, 30 to 60. For a toddler, 24 to 40. For an adult, 12 to 16 breaths per minute. Pay attention to the resistance you feel as the lungs inflate. Obstruction makes squeezing the bag more difficult, whereas a leak in the ventilation system makes squeezing the bag very easy. In both these cases, however, the chest won't rise. When in doubt, have a helper listen to the chest as you ventilate. You should hear breath sounds. Although there are some medical conditions where breath sounds are hard to hear, the absence of breath sounds almost always means inadequate ventilation. If an end-tidal CO2 device monitors the patient, you should see evidence of exhaled CO2. Always use the least force required to effectively inflate the lungs. It takes a lot less force to give a 50 milliliter breath as opposed to a 900 milliliter breath. Too large a tidal volume risks pneumothorax, especially with children. Relax the left hand slightly for the few seconds it takes for the bag to refill. Gripping the mask too tightly can cause your hand to cramp. If your fingers spasm, you'll lose fine motor control and have difficulty maintaining a seal. If you have a good mask seal, little or no air will escape around the mask. You can tolerate some leak as long as you can ventilate the patient. If you don't have a good seal, then you must get a better fit. Typically, the leak will be on the side with the bag opposite the hand holding the mask. To improve fit, rotate the ventilation bag attachment to change the point of maximum pressure. Reposition your hands. If you have an assistant, ask her to push the cheek up against the outside of the mask at the leak sites. Hypoxemia rapidly causes bradycardia in children. When a child develops bradycardia, treat for hypoxia first. Recheck your hand position and oxygen source. Increase the depth and rate of ventilation. The heart rate usually returns to normal quickly, although atropine may also be needed. Intubation in children requires the same basic equipment as in adults, but the technique used must take into account the anatomical differences. Placement of an endotracheal tube through the larynx interferes with its natural protective functions. Therefore, we must use techniques and equipment during and following intubation to minimize the risk of aspiration. We use a laryngoscope to see the larynx during oral intubation, a technique called direct laryngoscopy. A pediatric laryngoscope handle is thinner and lighter, making it easier to manipulate the smaller anatomy. Pediatric intubating equipment should include Miller or straight blades in size 0 for infants, 1 for 1 to 2 years, and size 2 for older children. You may want to have a MAC available as well. Although you can intubate an infant or toddler with a larger blade, it's technically much more difficult. The larger blade often interferes with visualization and gets in the way of passing the tube. It also carries greater risk of injuring the oropharynx. It's easier to use a straight blade in children because the larynx is located much higher in the neck than an adult. A straight blade lifts the epiglottis to allow a clear view of the vocal cords. A curved blade, like a MAC, is designed to fit into the vallecula and displace the soft tissue forward to provide a view of the larynx. However, in a child, the MAC will sometimes fold the child's epiglottis down over the larynx, blocking your view of the cords. When using a curved blade in a child, consider using it like a straight blade to lift the epiglottis if this is happening. Always check your equipment prior to use to avoid equipment failure at a critical moment. Have at least 3 endotracheal tubes immediately available, the predicted size, 1 size larger, and 1 size smaller. You lose valuable time looking for a different tube if you have difficulties. The larger the tube you insert, the less resistance to breathing and the easier it is to keep free of secretions. Have smaller sizes immediately available, especially in the presence of trauma or swelling. The endotracheal tube has 2 openings on the patient end. The side opening, called a Murphy eye, prevents obstruction when the tip of the endotracheal tube is up against the tracheal wall. The beveled tip serves the same purpose when the tube tip is against the carina. Premature infants take a size between 2.5 and 3 millimeters internal diameter, or ID. Neonates usually take a 3 to 3.5. Infants from 3 to 13 months usually take a 4, and those between 1 and 2 years need a 4.5. Over the age of 2 years, a convenient formula, the age in years divided by 4 plus 4.5, is fairly accurate in predicting the correct tube size. For example, a 6-year-old would take a size 6. The correct size tube is often the same diameter as the child's little finger. Positive pressure ventilation depends on providing enough pressure to inflate the lungs. If there's a break in the pressure seal, such as through a leak back out through the glottis around the endotracheal tube, then ventilation may be inadequate, and the patient may potentially aspirate around the tube. We use cuffed endotracheal tubes to provide the seal in adults, but not usually in infants and small children because their larynxes are anatomically different. In a child younger than about 8, the smallest diameter of the airway is the cricoid ring. A properly sized round endotracheal tube will seal this round cricoid opening, and using an uncuffed tube allows us to use a slightly larger size and therefore avoid higher resistance to breathing. In an adult or child older than about 8, the opening through the vocal cords is smaller than the cricoid. The vocal cord gap is triangular in shape and a round tube won't seal it. Therefore, a cuff below the cords is now needed to provide the seal. For a child older than 8, choose a cuff tube 1/2 size smaller than the predicted size to allow room for the volume of the cuff. Endotracheal tubes have depth markings in centimeters. Insert an uncuffed tube until the lowest, most prominent mark is level with the vocal cords. Insert cuffed tubes until the cuff just passes through the cords. Make sure your stylet, if you use one, does not extend beyond the tip or through the Murphy eye where it could damage the trachea. Have your suction ready for use. In addition to a usual Yankauer suction tip, have soft suction catheters small enough to suction inside the smallest endotracheal tube you intend to insert. To intubate, you need to bring the path from the incisor teeth to the larynx into a reasonably straight line. This path has 3 axes: the oral axis, the pharyngeal axis, and the laryngeal axis. Since these axes don't naturally line up, aligning the axes requires optimally positioning the patient's head and neck, and then using the laryngoscope blade to make the final adjustment. Optimizing head position is a key step for success. Infants may need a small towel under their shoulders to compensate for their prominent occiput in order to bring their airways into alignment. Older children may need a small towel under the head. The laryngoscope blade then lifts the mandible to bring the oral axis in line with the other 2. The larynx usually comes into view. Other techniques can be used in situations when the patient's head and neck should not be moved, such as cervical trauma. Oxygenate the patient well before starting. Intubation is accomplished in a smooth, coordinated sequence of alternating hand motions. To intubate, extend the head but avoid hyperextension, which can obstruct the pediatric airway. Lift the blade with your left hand with the blade facing away from you. Insert the blade as far to the right side of the mouth as you can, and then sweep the tongue to the left. Control of the tongue is essential, or you won't have room to pass the tube. Slowly lift the mandible upward as you advance. Be careful to avoid pinching the lower lip between the teeth and the blade as you lift. Also avoid using the upper gum line or teeth as a lever, or you will break teeth. Continue to lift the mandible upward until you see the narrow epiglottis above, the bulges of the arytenoids at the bottom, and the vocal cord stretching between. Be gentle. Traumatic intubations can cause swelling, which can be especially dangerous in the child's small larynx. Use suction as needed. If you can't identify anatomy, then the blade may be in the esophagus. Often the larynx falls back into direct view as you slowly pull the blade back into position. Pick up the tube with your right hand. You can also ask your assistant to hand it to you in the correct orientation for insertion. Hold the pre-selected tube in your right hand like a pencil, curve forward. Keep your eyes on the trachea and maintain control of the blade. Insert it to the right side of the mouth and watch it pass through the vocal cords. Stop when you see the lowest marker ring past the cords. While there may be a blind spot at the moment of entering the larynx, you can often see the arytenoids behind the tube. Carefully remove your laryngoscope blade. Change to a smaller size if the tube won't pass easily. Forcing a tube can cause traumatic swelling. Children can't hold their breaths as long as an adult before the onset of hypoxia. If you have trouble intubating, stop and ventilate before trying again. During awake intubations, let the patient rest and breathe oxygen. Lack of ventilation hurts patients, not the lack of an endotracheal tube. Continue to hold the tube with your fingers at the lips until it's secured. Head position and movement of surrounding tissues shifts cartilages and may affect your ability to see the vocal cords. Sometimes the larynx lies anterior to your field of view during laryngoscopy. This is a so-called anterior larynx, and it occurs with poor head positioning, as well as in patients with obesity, larynxes located higher in the neck than average, and in patients with poorly developed mandibles or weak chins. If you can't see the vocal cords during intubation, have an assistant provide cricoid pressure. The thumb and index fingers straddle the cricoid ring and push the cricoid cartilage downward firmly but gently against the vertebral column. Never assume the tube is in the trachea. Verify tracheal placement by listening over both axilla in the stomach. Easy transmission of sound makes esophageal intubation harder to detect in a child. Breath sound should be equal and chest movement symmetrical. Stomach distension may indicate an esophageal intubation. Depth of tube placement is critical because the trachea is quite short. The tip of the tube should be midway between the larynx and the carina. When the tube is too far down one side of the trachea, it will lie in one mainstem bronchus and block the other. This is called a mainstem intubation. In this case, you ventilate only one lung and you will hear breath sounds on only one side of the chest. The chest will rise unevenly. Slowly pull the tube back while listening until breath sounds appear on both sides. Extension of the neck causes the endotracheal tube to rise within the trachea. Inadvertent extubation can occur if the tube is too high. Flexion of the head causes it to descend, possibly causing mainstem intubation. A good guideline for the initial depth of insertion is to use the formula, the age divided by 2 plus 12. For example, a 6-year-old would have a tube inserted to the depth of 15 centimeters. Listen at the child's mouth. Unlike an adult, we want to hear a leak around an uncuffed tube at about 20 centimeters of water pressure, after the child's lungs are fairly well inflated. The absence of a leak at 20 centimeters means that the tube is too large and pressing on the inside of the cricoid ring. Excessive pressure inside the cricoid can damage the mucosa and potentially injure the recurrent laryngeal nerves. A leak is too large if it prevents effective inflation of the lungs. Consider switching to a more appropriate tube size when the situation or the stability of the patient permits. In older children, when you're using a cuffed tube, check for a leak before you inflate the cuff. If there is a leak, inflate the cuff until the leak just vanishes. If there is no leak, leave the cuff deflated. Tape the tube in position and document the depth of insertion. Re-verify equality of breath sounds. If they're no longer equal, remove the tape, reposition the tube, and listen again. Even after it's taped, hold the tube securely when moving the patient. Tubes frequently move during transport. Re-verify placement after every move. Flexing the neck of a child with possible cervical spine injury can potentially cause permanent injury or paralysis. Often such patients are intubated with specialized equipment by experienced intubators. If you need to intubate such a patient in an emergency, have an assistant hold the head and neck in a neutral position while you intubate. Lift only the mandible, not the head and neck. Extubation is a potentially dangerous time. Have suction, oxygen, and the means to reintubate the patient immediately available. Apart from vomiting and aspiration, the most serious complications following extubation include laryngospasm, post-obstructive pulmonary edema, post-extubation croup, and respiratory insufficiency. Laryngospasm is reflex spasmodic closure of the vocal cords. It can occur when the vocal cords are stimulated in a semi-conscious patient, such as stage 2 of an anesthetic induction or emergence, a time when airway protective reflexes are hyperactive. Early extubation is one common cause. If laryngospasm occurs, suction the airway clear of secretions, use jaw thrust, and apply positive pressure ventilation administered by bag valve mask. If the spasm doesn't break, sedative drugs and/or muscle relaxants may be needed. To prevent laryngospasm, ensure the pharynx is clear of secretions, avoid stimulating the vocal cords in a semi-conscious patient, and extubate the patient either awake or in a deep plane of anesthesia, but not semi-conscious or in stage 2. Patients with post-obstructive pulmonary edema, or POPE, develop sudden, unexpected, and potentially life-threatening pulmonary edema after relief of airway obstruction. POPE type 1 follows acute airway obstruction. POPE type 2, which is much less common, develops after surgical relief of chronic upper airway obstruction, such as tumor. POPE 1 occurs when forceful attempts to inhale against an obstruction create highly negative intrathoracic pressure. This in turn increases venous return, decreases cardiac output, and forces intravascular fluid to shift into the alveolar space in the lungs. The typical POPE patient is young, healthy, and strong. A common case history for POPE type 1 is the patient who goes into laryngospasm immediately following extubation, resulting in transient airway obstruction. The patient then complains of dyspnea and respiratory distress. Symptoms range from mild, unexplained hypoxemia to severe, requiring reintubation and ventilatory support. Clinical signs include tachypnea, tachycardia, Rales, and rhonchi. Symptoms usually begin within an hour, but have been reported as late as 6 hours. Treatment consists of supplemental oxygen and support. Reintubation may be required with provision of low levels of positive end expiratory pressure. Full and rapid recovery can be expected with appropriate management. Post-extubation croup is caused by inflammation of the subglottic region due to mechanical irritation from the endotracheal tube. It's most common in children 1 to 4 years old. Other contributing factors include trauma during intubation, a tight-fitting tube with no leak at 25 to 40 centimeters of water pressure, surgery in the neck region, children with previous history of croup, and a duration of intubation of more than 1 hour. The problem is the effect of a small amount of edema on the diameter of the subglottic space. 1 millimeter of circumferential edema in an average adult with a 10 millimeter cricoid opening reduces that opening 20%, leaving considerable reserve. The same 1 millimeter circumferential edema in a baby's 3 millimeter cricoid reduces the opening by almost 70%. Treatment includes humidified oxygen and aerosolized racemic epinephrine, which helps to shrink the mucous membrane. Because swelling can worsen again after the epinephrine effect wears off, it's important to continue to observe the patient for recurrence. If obstructive symptoms are severe and do not resolve with treatment, the patient may need to be reintubated until swelling resolves. Complications can occur during and following intubation. First of all, the process of intubation can delay ventilation and result in inadequate oxygenation, hypercarbia, or interruption of CPR for greater than 15 seconds. In addition, the stress of the intubation can cause physiologic responses that can put the patient at risk. Hypertension and tachycardia increase the risk of heart attack and stroke. Complications are much more likely to occur in difficult intubations and emergency situations, especially in out-of-hospital locations where distractions can interfere and poor intubating conditions such as patient position and poor ambient lighting are likely to exist. Potential complications include tooth trauma, eye trauma, esophageal intubation, bronchospasm, endobronchial or mainstem intubation, premature or unintended extubation, aspiration, pneumothorax, spinal cord injury, increased intracranial pressure, and the loss of the airway and airway obstruction, which, if uncorrected, can lead to hypoxic injury and death. Airway management and intubation in children are more challenging because their anatomy and their responses to stress are different than adults. Don't hesitate to ask for help or to allow a more experienced intubator to take over. Complications can occur even if perfect medical management is followed. Keeping these differences in mind will minimize the risks.